بسم الله الرحمن الرحيم. اهلا وسهلا. lucky enough ان احنا هنبتدي سيشن very interesting في الحقيقه. ليه؟ احنا عرفنا كتير عن هايبرتنشن، وعرفنا how to measure blood pressure in a classical way، وعرفنا ال various methods to control. انما احنا نتيجه لللونجر لايف سبان والايجز عليت، من النادر دلوقتي ان يجي لك حاله هايبرتنشن بيور كده، مفيش فيها حاجه غير ان هو هايبرتنشن. اغلب الحالات اللي بتجيلك بيبقى هايبرتنشن وحاجه كمان او حاجتين كمان. ده موقف احنا بنقابله in our clinical work، وعشان كده ده حاجه احنا بنشوفها في الشغل بتاعنا. عشان كده السيشن ده يعني المفروض انه فيري انترستنج. كنت اتوقع ان يبقى فيه حضور اكتر من كده. في حالات هايبرتنشن مع ليفر ديسيز، هايبرتنشن مع كيدني ديسيز، هايبرتنشن مع اتريال فايبريليشن، هايبرتنشن مع انتي كواجوليشن، هايبرتنشن مع سيربرال فاسكولار اكسنت. الكلام ده كله مهم، لان مش كل حاله بنفس الطريقه، كل حاجه لها سبيشال ميريتس في ان انا اقدر اواجه الحاله مش هايبرتنشن بس، الحاله والحاجه اللي معاها.
بسم الله الرحمن الرحيم. برحب بحضراتكم. وطبعا دكتور احمد تفضل بالمقدمه المهمه دي، ويسعدني طبعا ويشرفني ان انا اقدم الاستاذ الدكتور تيمور مصطفى to present the blood pressure control in atrial fibrillation patients on anticoagulation. تفضل.
بسم الله الرحمن الرحيم. شكرا دكتور طارق. Mr. Chairman, dear colleague. Today we talk about the topic of blood pressure control in AF patient on anticoagulation. This slide will summarize what we are going to talk about. We have patients with hypertension, which will lead them to have atrial fibrillation. Both will be a risk factor for stroke. And in such patient, we should take care about both the leading risk, and we are going to assess with the Hasblad, and the ischemic risk that should be assessed by the Schatzbask score. Okay, let's go to our presentation. Hypertension AF are two important public health priorities, and hypertension is the most powerful predictor of mortality in high and low income countries. Prevalence 20 to 50% of hypertension worldwide, and atrial fibrillation is the most frequent cardiac arrhythmia. AF is associated with a 5-fold increase in the risk of stroke, 3-fold increase in the risk of heart failure, and a 2-fold increase in the risk of mortality. In Europe, we have about 9 million patients in 2010, which is increasing to almost doubled in 2050. And 1 to 2% of the total population have atrial fibrillation. If you are talking about patients above 75, it may reach up to 10%. Hypertension and atrial fibrillation often coexist. For example, in the Framingham Heart Study, hypertension portended an excess risk of AF by 50% in men and 40% in female. In the Ike study, hypertension was the main contributor to the burden of atrial fibrillation, explaining about 20% of new cases. In those with established atrial fibrillation, hypertension is present in about 60 to 80% of patients. So, do hypertension predispose to atrial fibrillation? Actually, this was a matter of a lot of studies started a long time ago. All what we are seeing now in this slide are studies talking about the mechanisms how hypertension can produce atrial fibrillation. This is a summary of these slides, of these studies. Hypertension causes hemodynamic changes in the form of reduction of the left ventricular diastolic and systolic function, increase of the left atrial pressure, stiffness with left ventricular hypertrophy, RAS activation, autonomic dysregulation, structural remodeling with increased left atrial size. Ultimately, we are going to have the atrial fibrillation. Another important proposed mechanisms in the activation of the angiotensin system, resulting in increased progression of atherosclerosis, increase in myocyte volume, fibrosis, increase the left atrial pressure, increase intracellular calcium with a reduction of the atrial refractory period, will end by electrical remodeling and atrial fibrillation. So why we care about patients with hypertension and atrial fibrillation? In AF patient, hypertension exerts a multiplicative effect on the risk of experiencing stroke and bleeding events. And so in such patients, it's very important to adequately control blood pressure. And again, we remember such patients with AF and hypertension are going to take either NOAC or vitamin K antagonist. What is the impact of hypertension on stroke or systemic embolization? Patients with hypertension had a higher risk for ischemic stroke and systemic embolization and for hemorrhagic stroke compared with those without hypertension at baseline. A couple of studies showing that an increase of blood pressure systolic by 10 millimeter mercury will cause a 6 to 7% increase in the risk of stroke. Again, in the ENGAGE AF trial, among hypertensive patients, stroke and systemic embolization increased from 1.5 to 2 if the blood pressure increased systolic from 140 to 150. What about the impact of hypertension on bleeding outcome? Actually, there is no increased risk of bleeding complication was found in those with or without a history of hypertension. But in a secondary analysis from the ENGAGE AF trial, the authors found an increased risk for major bleeding in those with uncontrolled versus controlled hypertension. We are talking about blood pressure more than 150 systolic. What about the impact of hypertension on the comparative efficacy and safety of NOACs versus VKA? Actually, all studies showing that patients with NOAC treatment have no difference in the efficacy if they are treating either hypertensive or non-hypertensive patient. And again, in hypertensive patient, either they are controlled or not, they have the same effect. Like in this study, it's comparing the effect of NOACs in patients with controlled and uncontrolled hypertension in terms of reduction of stroke, hemorrhagic stroke, intracranial hemorrhage, and major bleeding, and they are almost the same. Why we talk about hypertension and atrial fibrillation? Because we have a double trouble. Prevention of stroke is important to manage patients with atrial fibrillation, which involves use of oral anticoagulation, as we said, in the presence of risk factor. One of these important risk factors definitely is hypertension. And as we know that patients with atrial fibrillation have a higher bleeding risk event, most notably is increasing intracranial hemorrhage risk, which is related to the use of oral anticoagulant therapy, as well as higher intrinsic risk of bleeding. Similarly, the presence of uncontrolled hypertension is an important risk factor for bleeding, both in anticoagulated and non-anticoagulated patients. And this will require from us adequate blood pressure control in such patients. What about the oral anticoagulation in hypertensive patients? As we all know that the guidelines use the Schatz-Vask score for simplifying the decision to start the use of oral anticoagulation. And according to the guidelines, you have a male patient with atrial fibrillation with a score of 2 or a female with a score of 1, you are going to initiate the anticoagulation. And definitely nowadays, according to the guidelines, we are going to use a DOAC in favor of the use of vitamin K antagonist. And as we know from the Hasblat score that arterial hypertension, especially with a systolic blood pressure, is more than 160 over 100, represent a significant risk factor for bleeding in such patient. A very important study is the BAT study, which was conducted in about 4,000 patients. The purpose of this study was to clarify the association between major bleeding and blood pressure level preceding bleeding event in antithrombotic users. What do they found? In this study, systolic blood pressure levels during follow-up period were strong predictor with a 45% and 47% increase in the risk of stroke at 1 month and 6 months follow-up for each 10 millimeter mercury increase in the blood pressure. Another important study is the PROGRESS trial that enrolled the patient with previous stroke or TIA. 72% of the patients were under antiplatelet therapy and 10% on oral anticoagulation. They found that a reduction of systolic blood pressure by 9 millimeter mercury caused a reduction of the relative risk of hemorrhagic stroke by 50%, which increased to 67% reduction if you cause more reduction in systolic blood pressure by about 12 millimeter mercury. The intensity of anticoagulation involves a balance between thromboembolism and hemorrhage. That's why you are going to use the Hasblad score. One of the most important points that if you have a patient with a high Hasblad score, this does not mean that you are not going to give him the oral anticoagulation. This means that you should take care of this patient because he has high bleeding risk, and our job at that time is to modify all the reversible risk factors which cause him at risk of bleeding. We have a lot of randomized controlled trials with the oral anticoagulant, for example, with warfarin compared with aspirin for the reduction of the risk of stroke, but none of them involve specific blood pressure level. In the SPORTIF 3 and SPORTIF 5 studies that compared zemilagatran, which is no more used nowadays, compared with warfarin in AF patient, the blood pressure levels during the follow-up were recorded. And they found that event rate, namely stroke and systemic embolization, significantly increased a systolic blood pressure of more than 149. Other recent randomized controlled trials in patients with direct oral anticoagulant, like the RELY trial using the dabigatran, actually 79% of the participants have hypertension. In this study, blood pressure control was adequate, and the authors affirmed that every 10 millimeter mercury increase in the mean and systolic blood pressure increased the risk of stroke by 6 to 7%. Again, in the ROCKET trial using the rivaroxaban, about 90% of patients were hypertensive. And in a retrospective analysis of the ROCKET trial, the investigator found that every 10 millimeter mercury increase from the baseline systolic blood pressure caused the adjusted risk of stroke or systemic embolization increase by about 7%. In the Aristotle trial using the apixaban, 88% of the patients with hypertensive. And in a post-hoc analysis of the Aristotle trial, they found that blood pressure level more than 140/90 increased the risk of hemorrhagic and thromboembolic event at any point of this study. So, what is the optimal blood pressure target in AF patient? If you are going to talk about the guidelines, the UK, the Canadian, and the Australian guideline, they do not list patients with AF as a specific population. On the other hand, the European and the Chinese, they're talking about blood pressure reduction systolic of less than 140, and if well tolerated, less than 130. In the Japanese, patient with AF less than 130. In the Korean, patient with AF less than not less than 120/70. And in the ACC, AHA, in general, including patient with atrial fibrillation, we mean a blood pressure is less than 130/80. In the SPORTIF 3 and 5 trials, the authors found that increasing the rate of ischemic stroke and systemic embolization with increasing quartile of systolic blood pressure, in which event rate increased markedly at a mean systolic blood pressure of more than 140. And in the ROCKET and Aristotle trial, event rate were lower in patients with controlled blood pressure, systolic less than 140, and uncontrolled hypertension, 140 millimeter mercury systolic. In the ENGAGE AF, suggests that systolic blood pressure of 110 to 130 may present as the most optimal target for minimizing stroke risk in anticoagulated patients with AF and hypertension. Another important Korean study involving about 300,000 patients found that blood pressure of 120 to 129/80 had the lowest risk for major cardiovascular event compared with patients with higher and lower blood pressure. An important Swedish study, which was conducted in about 4,000 patients, they found that systolic blood pressure in the 140/180 millimeter mercury range prior to initiation of oral anticoagulation is associated with more than double risk of hemorrhagic stroke as compared with a systolic blood pressure of than 130. And they suggested that lowering systolic blood pressure to below 145 is important before initiation of anticoagulation. The final study we talk about today is a study conducted in England in about 9,000 patients taking DUACs. They found that the systolic blood pressure for lowest event rate was 120, and for lowest cardiovascular mortality was 130. Future direction is important. Using a randomized intervention study are warranted to investigate whether, 1 minute. More stringent blood pressure control will cause, first, improve the cardiovascular outcome, and second, outweigh the risk, including hypotension, syncope, electrolyte abnormalities. Our conclusion that hypertension is a powerful trigger for atrial fibrillation and the increased risk of cardiovascular events in patients with AF. No doubt that oral anticoagulation therapy is mandatory in patients with AF. However, we should always respect and control blood pressure level. Anticoagulation in patients with AF and hypertension is challenging, since uncontrolled hypertension increases markedly the risk of thromboembolic and hemorrhagic events. To date, evidence support targeting blood pressure at guideline recommended level for primary prevention and the management of AF with the respect of the U or G-shaped curve. Systolic blood pressure is suggested to be reduced below 140 millimeter mercury, 145, before starting anticoagulation, and kept between 129 to 120 during therapy according to the available data. Thank you.
شكرا يا دكتور تيمور for this elegant presentation. يمكن انا بس عايز 2 points كده نسترس عليهم. احنا الهايبرتنشن per se is a risk factor for new onset atrial fibrillation. Up to 20-25% of hypertensive patients may develop atrial fibrillation at time. What are the predictors that those patients with hypertension will develop new onset atrial fibrillation? دي أول حاجة. تاني point, the risk, the goal of blood pressure. يعني we need intensive blood pressure lowering in patients with hypertensive and atrial fibrillation because the risk of stroke is high. Sprint trial found that intensive blood pressure control قلل risk of stroke. For those patients with atrial fibrillation and hypertension at a higher risk for stroke, we need more intense. يعني انت ذكرت more data او guidelines او انما in your practice يعني it's better ان العيان ده يوصل ل 120 او اقل من 120 to prevent stroke.
اول حاجه طبعا الهايبرتنشن زي ما حضرتك قلت ان هو كبريدكتور للديفلوبمنت اوف اتريال فايبريليشن. احنا الحقيقه في ثيوريز كتيره جدا على الموضوع ده، كلها ريليتد لان البيشنت دول طبعا بيبتدي يديفلوب الكتريكال ابنورماليتيز مينلي ريليتد الى الانكريز الليفت فنتيكولار اند دايستوليك بريشر، وبعدين السيستوليك ديسفانكشن وانكريز الليفت اتريال بريشر بيخلي البيشنت ده از مور برو تو ديفلوب اي اف. العيان دول برضه غالبا عندهم مايترال ريجرش، العيان اللي عنده دايستوليك ديسفانكشن ده بيساعد برضه ان يبقى فيه ليفت اتريال دايليتيشن برون ان البيشنت يخش فيه اتريال فايبريشن. ال في اتش واحده مهمه وبالظبط كده، والانكريز الليفت فنتيكولار اند دايستوليك بريشر كلها، والاكتيفيشن اوف رينين انجيوتنسين سيستم، حاجات كتيره بروبوزد ميكانيزمز ان تنتهي بان البيشنت از مور برون تو ديفلوب اي اف. زي ما حضرتك قلت ان احنا 20 او 25% من بيشنت ويز هايبرتنشن وي ار جوينج تو ديفلوب اتريال فايبريليشن. الحقيقه الاجابه على السؤال ده ايه الاوبتيمال بلاد بريشر اللي احنا نتارجت في عيانين الاي اف؟ احنا جايد لاينز اول حاجه لو بنتكلم على اليوروبيان جايد لاينز مثلا هي مش حاطه الاي اف كسبيسيفيك انتيتي، بس انا بقول ان انا البيشنت هيبقى اقل من 140 ولو قدرت اوصل اقل من 130 سيستول بلاد بريشر اتس اوكي. لو بنتكلم ان انا مش عايز انزل عن ايه، الوحيدين اللي اتكلموا احنا مش عايزين ننزل عن ايه اللي هم الكوريان جايد لاينز، قالت احنا مش عايزين العين يقل عن 120 على 70. ده بالنسبه للجايد لاينز. الامريكان جايد لاينز بنتكلم ان احنا بلاد بريشر اقل من 130 80 كجنرال، ما قالش برضه الاي اف كسبيسيفيك انتيتي. لكن الحقيقه في كذا ستادي قلناهم في الذكر واحنا بنتحدث في البرزنتيشن ان احنا ان انا اولا ما ابتديش انتي كواجيليشن الا لما يكون السيستوليك بلاد بريشر اقل من 145، لان اذروايز البيشنت ويل بي ات ا هاير ريسك اوف ديفلوبينج ستروك او هيموراجيك ستروك. الحاجه الثانيه تراي تو كيب السيستوليك بلاد بريشر اقل من 130، لو قدرت امشيه ما بين 129 لحد 120 يبقى كويس جدا، ومش هنزل بيه الدايستوليك عن ال 70. ده according to available data الاوبتيمال blood pressure control either before initiation او continuation of anticoagulation في العيان الهايبرتنشن.
I'm impressed الحقيقه باليور ليكشر، وطبعا مهم جدا وواضح للكل ان احنا مش ممكن ندي الانتي كواجولانت ثيرابي الا اذا كنا شور ان البلاد بريشر نزل تو ريزونبل ليفل، و 130 80 كلام معقول جدا. بس في نقطتين في الموضوع. النقطه الاولانيه ان انا لو حاولت انزل بلاد بريشر اكتر من كده في الاولد ايج، كان في كلام كتير اتقال بالنسبه للدياستوليك لو نزل منك اقل من 60 او اقل من 50. هنا بيبقى في دينجر، لان احنا عارفين ان الدياستوليك بلاد بريشر ده is very important for the blood supply of myocardium. myocardium gets its blood supply during diastole اكتر من السيستولي. فلو انا الدياستولي وطي اكتر من 60 او اكتر من 50، في دينجر في الاولد ايج ان البرفيوجن اوف مايوكارديوم يقل، وذيس كان بي cause of stroke by of infarction by itself. الكلام في ده كتير وفي كونتروفيرسي، وانما طبعا احنا نبقى حريصين لما ننزل البلد بريشر 120 تاخد بالك من الدياستوليك بقد ايه، ان احنا نحاول ان هو ما ينزلش ابدا عن 50. دي 1 بوينت. 1 بوينت حاجه تانية بقى، دي يعني بيرسونال اوبزرفيشن لي انا، ان انا انت دلوقتي بتقيس البلد بريشر اندر يعني سبيشال كونديشنز، ان البيشنت هادي وقاعد ومستريح وظهره مسنود والكلام ده كله، وبعدين بتقول البلد بريشر بتاعه 130 80. العيان ده مش تمثال قاعد، ده عيان بيمارس الحياه. العيان ده لو تنرفز، لو اتخانق، لو اتخض، لو سمع خبر وحش او اي حاجه، وجه وهو اندر انتي كواجولانت ثيرابي، وجه البلاد بريشر شايط بقى 180، ده مش بني ادم قاعد يعني في برج عاجي. هنا اهو يخش في سيريبرال هيموريج. احنا لو كان البليدنج اللي بيحصل ابستاكسس ولا هيماتوريا ولا حتى هيماتيمسس، هنا يعني بتقدر تعمل حاجه، بتقدر تسيب البيشنت. انما في اغلب الحالات انت لو دخلت في السيريبرال هيموريج العيان ضاع. وعشان كده ده يعني الحاجه اللي دريتفول بالنسبه لنا. انا بعمل ايه؟ انا كل الحالات اللي زي ده اهي بدي ترانكلايزر معاه. الكلام ده مش مكتوب في حته، ومعلش دي بيرسون اوبزرفيشن، يعني ما تاخدش بيها او ما تسمعهاش، لكن انا دايما بدي ترانكلايزر، بحط في حسابي ان العيان ده ينفعل او يخش في اي سيتويشن يشوط السيستوليك ل 170 ولا 180، فمش هيخس عليه حاجه اما اديله ترانكلايزر دايما مع العلاج ده. ثانك يو.
شكرا دكتور تيمور على المحاضرة الكريمة. أنا كان نفسي براكتي اللي بس أسأل أنا العيان عندي فيه مشكلتين، هو اي اف وهو هايبرتنسيف. الاي اف لازم تديله انتي كواجوليشن، وهايبرتنشن وممكن ده يعمل له بليدنج، والهايبرتنشن السيفير ممكن يعمل له بليدنج. فامتى بقى براكتيكالي اعمل كنترول البلاد بريشر الواتش ليفل وابدا معاه، لان لازم هياخد انتي كواجوليشن؟ امتى ادي العيان اوصله مثلا هايبرتنسيف سيفير هنزله الواتش ليفل وابدا معاه الانتي كواجوليشن؟ ده براكتيكالي بقى هبدأ يعني.
الاستادي الوحيد الافيدنس اللي هي السويدش ريجستري دي كانت معموله حوالي 4000 عيان، عملوا فولو اب لمده 10 سنين، ولقوا ان هو احنا العيانين اللي هم البلاد بريشر بتاعهم معدي ال 145 لحد 180، لو قارناهم بالناس اللي هي البلاد بريشر بتاعها اقل بالذات من ال 130، فرق كبير قوي الاثنين في الديفلوبمنت اوف هيموراجيك ستروك لما تبتدي معاهم الاورال انتي كواجوليشن. هم طلعوا بتوصيه في الاخر ان انت لازم السيستوليك يكون اقل من 145 عشان تبتدي انتي كواجوليشن كبدايه. انما طبعا احنا لو بنتكلم كمينتنس زي ما احنا شفنا او كالايفيدنس بيز او جايد لاينز كلها، احنا عايزين بلاد بريشر يكون سيستوليك اقل من 30 ما بين 120 لحد 129، ده الاوبتيمال تو كونتينيو الانتي كواجوليشن. لكن كبدايه لازم يكون اقل من 145، لان هي الوحيده اللي قالت كبدايه ابتدي من امتى هي السويدش ريجستري دي، وكانت على رقم برضه 4000، ده رقم كبير، وعملوا فولو اب 10 years، رقم فتره ديوريشن كويسه جدا. فاعتقد ان اقل من 145 اقل من 140 ده جود انيشيشن للاورال انتي كواجوليشن.
شكرا يا دكتور تيمور. طبعا الموضوع عايز وقت جامد، ولكن فور شورتج اوف تايم طبعا يسعدني ويشرفني ان طبعا احنا بنقول دايما الهايبرتنشن ويز كوموربيديتي، الموست كوموربيديتي هو الليفر ديزيز. فيسعدني ويشرفني ان اقدم الاستاذه الدكتوره غاده كزامل the optimum blood pressure management post liver transplantation.
Good morning. First, I'd like to congratulate the organizing committee, especially Upper Egypt universities, for this high scientific content. I saw it is 32 credit hours, which is huge. My chairperson, my colleague, I'm Dr. Ghada Qazamin from National Heart Institute, and I have nothing to disclose. My presentation about taking care about the hypertensive patient, especially after liver transplant. Instance is completely different because we should to classify, we should to classify the instance into three elements. The first element is the early post transplant. We found that after liver transplant, after 4 weeks, there is increasing the incidence of the hypertension, which may elevate it to 50 to even 80% of the liver transplant patient. The second is long term. Sometimes when we start to reduce the dose of cyclosporine, they found that some patients return to the normotensive side, but actually most of the patients continue in severe hypertension despite a reduction of the dose of the cyclosporine. The third instance is the pre-existing hypertension, which is very common because usually patient going to a liver transplant, they carrying a lot of comorbidities like diabetes mellitus, increasing age, renal problem, even cirrhotic cardiomyopathy, and usually one of the element and risk is hypertension. So the instance is completely different post-procedure or continue as a long term and pre-existing, but actually the instance is unknown. The type of hypertension, multiple type, not like the other essential hypertension or secondary hypertension, like we measuring the blood pressure and differentiating our blood pressure, but it is may be related to the procedure itself. So post transplant hypertension may occur de novo. The patient is not hypertensive before, but starting to become hypertensive after the procedure. It may be due to a medication like is a cytotoxic drug which is given to the patient. One of its side effect is producing hypertension because it reduces the circulating endothelin and prostacyclin, which is leading to increasing in the peripheral resistance, and cirrhotic cardiomyopathy, which may be associated to the patient with liver transplant, which causing a lot of the affection in the hemodynamic and the cardiovascular system, including the diastolic dysfunction, the increasing the intimal thickness, and all that may inducing the hypertension. Another element which is not very common to the cardiologist, but it is common to the hepatologist and the transplant specialist, the portal hypertension, because portal hypertension may carrying a lot of problem related to increase the shunt which is present and produce a secondary hypertension to the patient due to changing in the hemodynamic. Diabetes related hypertension, which is very common in the patient with liver transplant. And the other element which was astonishing to me, despite it is rare, it is a catecholamine induced hypertension. There is an instance for a catecholamine secreting tumor which was found after liver transplant. Despite it is rare, but it is present, and circulating adrenaline and noradrenaline lead to this hypertension. Why it is this very important? Because if we know the type, if we know the causes, we can put the proper management for the patient. The causes immunosuppressive drug is a very crucial calcineurin inhibitor, including the cyclosporin, and also corticosteroids carrying a very important cause for elevating of the blood pressure, because it increasing the peripheral resistance, it increasing the it reducing the GFR and causing sclerosis of the renal arterioles. So it is another element. It reducing the circulating endothelin, and all these cause lead to hypertension. Obesity and metabolic syndrome is a very important cause, and it is very important association with a patient with transplant. Endocrinal disorder like hormonal imbalance, including a hyperaldosteronemia and thyroid dysfunction carrying a cause. Psychosocial stress, especially when the patient has a lot of question to be known. I'll go to my ordinary life. What about the mortality after transplant? The stress during the procedure, which all carrying a risk for development of hypertension. Risk factor, age, obesity, family history of hypertension, and even family history of transplant, diabetes mellitus, all these carrying a risk to develop hypertension even in de novo patient. Chronic kidney disease, alcohol consumption, a surgical factor is very important and very unique for liver transplant. Intraoperative factors such prolonged ischemia, reperfusion injury, vasoactive medication, all these lead to a hypertension after a liver transplant. A cardiovascular disease as a pre-existing condition which containing a lot of other risk factors. Measurement of blood pressure after there is a difference range, but all literature saying that the goal less than 140/90, except some in the Swedish, they said that the optimum it should to be less than 130/80, but the problem, they didn't give the lower range. They give you shouldn't exceeding 130/80, but the lower range, nobody mentioned it. Available treatment as all lifestyle modification, which is very important, not only to control the blood pressure, but to keeping the graft function properly. Reducing fat, reducing salt intake, balanced diet, regular exercise. All this is very important to reduce the de novo appearance of hypertension and controlling the hypertension if it is present, and also reduce the incidence of hypertensive emergency and urgency, including hypertensive encephalopathy. Antihypertensive measurement with a lot of different, but the drug of choice is the group of CCBs, because they found that after transplant there is a severe vasoconstriction of the all arterioles in the body, and this need to a very potent vasodilator effect of the calcium channel blocker. Classification, priority للنفادipine and amlodipine, and they found that the other group like verapamil and eltiazem has another rule. Like verapamil, they found that it increase the concentration of cyclosporin in the blood. So it is very important to reduce the dose of cyclosporin after that. And in relation to eltiazem, they found that they carrying a very important role to keeping the graft function and to reduce a cardiovascular problem in the transplanted patient. So calcium channel blocker can be even very potent and can be used as a single drug in hypertension after liver transplant. Related to diuretics, we should to know that we should to differentiate the type of diuretics. We should to avoid diuretics may leading to azotemia or reducing the GFR of the patient, and we should also avoid to the potassium sparing diuretics, because potassium sparing diuretics is a major problem, because cephalosporin prevent the excretion of hydrogen, and potassium, so it may cause hyperkalemia and cause a very hazardous problem. Also, it may carry a deterioration of the kidney function. The other issue, hyperuricemia. For that reason, hydrochlorothiazide is not preferred, because after liver transplant, uric acid may achieve a very huge numerical number. For that reason, thiazide is not recommended. Related to beta blocker, we can use beta blocker, especially labetalol, with proper control of the blood pressure, because it is alpha and beta blockating, which is a potent drug. Alpha blocker can be used, and that was astonishing to me that ACE inhibitor and the ARBs is not a potent in this condition, because they found that after liver transplant, the renin-angiotensin system may be, the renin circulating is low, so it is weak to control the blood pressure, but it can be used in combination. Disease prevention and control is very important. First, regular controlling and monitoring of the patient to detect the early elevation of the blood pressure, so the health provider can control the blood pressure properly at the proper time. And we should to check the adherence to the medication, because actually most of the time the patient escape dose or even not compliant for medication. Regular follow-up by the health provider is very important, because it carrying not only controlling of the blood pressure, but also controlling the integrity of the graft, because hypertension and its complication, one of the cause to graft rejection. My take-home message, Mr. Chairperson, individualized treatment plan should be tailored for each patient with specific need, considering the predisposing factor and general condition, and it should to be done by team. This team including the transplant specialist, hepatologist, nephrologist, and the healthcare provider. And thank you.
شكرا يا دكتوره غاده فور ذيس يعني اليجنت برزنتيشن، وخصوصا احنا في ايجيبت دلوقتي احنا عندنا الهيباتيك ترانسبلانتيشن از انكريزنج. بالنسبه للتشويس اوف انتي هايبرتنسيف زي ما حضرتك قلت الكالسيوم شانل بلوكرز، انما يو كان كومباين
of choice.
كالسيوم شانل بلوكرز ويز بيتا بلوكر.
It can be combined with other drug. It can be combined. Even calcium channel blocker can combine with beta blocker and alpha blocker. This is a very potent, because most of the hypertensive patient has a problem related to the heart rate and the increasing heart rate, and the heart rate is independent risk factor for a lot of mortality and the overall mortality. So we can combine, but we should to take care about the lipid of the patient, the lipid profile, and the new onset diabetes.
طب لو عيان ما كانش هايبرتنسيف وديفلوبد بوست
Calcium
ترانسبلانتيشن
channel blocker will be more than enough.
انسيدنت هايبرتنشن او اللي بنقول نيو اونست هايبرتنشن، از ات كيورابل او ريفرسبل يعني، ولا خلاص هيبقى ويل استابليشد؟
20% of the patient after 1 year they found that they start to become normotensive, but more than 80% continue as
We
a
have to continue.
as a hypertensive.
Thank you for this scientific lecture. موضوع المحاضرة الحقيقة جديد بالنسبة لنا، لأن إحنا يعني عمرنا لما حالات الليفر سيروزس والهيباتوسيلر فيلير عمرنا ما فكرنا في هايبرتنشن أبدا. يعني احنا عارفين إن في فاسو دايليتور ماتيريال، فاسو دايليتيشن، الجنرال بريفرال فاسكولار،
لأن بيبقى في بريفرال، لأن بيبقى في فازو دايليتيشن مع الليفر ديزيز.
The development of cirrhosis في حالة hypertension may cure الهايبرتنشن بسبب. بس حضرتك وضحتي بقى الآن حالة الترانسبلانتيشن في أدوية وفي عوامل أخرى بتخش في الموضوع، هي دي اللي ممكن تخلينا نشوف هايبرتنشن في حالة بإمبيرد ليفر فانكشن. ده مش معتاد أبدا. وبعدين هو في الحقيقة بالنسبة لللاينز اوف تريتمنت أنا I believe إن calcium antagonists are the most suitable for this condition، لأن احنا لو اتكلمنا عن الدايوريتكس فيها مشكلة مع الليفر، اتكلمنا عن البيتا بلوكرز فيها مشكلة، يمكن the most suitable for this is الكالسيوم antagonist.
هو كانت النقطة إن بري ليفر ترانسبلانت بيستخدموا البروبرانولول في البورتال هايبرتنشن. بروبرانولول is not effective after transplant لأن الباثولوجي نفسه اختلف. أنا بقى عندي generalized vasoconstriction everywhere والسموث muscle need more relaxation. فبما ان الباثولوجي اختلف فالميديكيشن it should to be different.
شكرا دكتورة غادة على المحاضرة القيمة. والآن يسعدني ويشرفني إن أنا أقدم أستاذنا الدكتور إيهاب الحفني، أستاذ القلب ورئيس قسم القلب السابق بجامعة الأزهر، أستاذي طبعا وأفخر به يعني ومعلمي. ويسعدني إن أنا أقدمه. هيكلمنا على الهايبرتنشن with liver cell failure. اتفضل.
مستر تشيرمان، الحقيقه احنا هنبتدي من حيث انتهى الدكتوره غاده والدكتور تامر. احنا بنتكلم على الهايبرتنشن patient with liver cell failure whatever the cause is. To start with, the point is the incidence of hypertension in patient with end-stage liver disease or with liver cirrhosis is very minimal. The studies suggest that in only 3 to 7% of the patient with liver cirrhosis they have hypertension. And that the patient, they become normotensive. The patients who are hypertensive before the disease, they just become normotensive after the disease. This is the bad side of this is the good side of the bad situation. 24 hours, and it's not all through the day. In fact, what happens is that they find that the patient with hypertension or the patient with liver cirrhosis, they have a low blood pressure during the morning and a normalized, which it becomes normalized during nighttime. But the blood pressure can be increased, yes, when there is a renal involvement, or when, in the patient with alcoholic fatty liver, they are more exposed to elevated blood pressure than others. So let's have a look at the pathology. What happens, whatever the cause of the inflammations, hepatitis B, hepatitis C, whatever the situation is, we'll find that it extends into cirrhosis and portal hypertensions and more complications. The pathophysiology will find that when the liver is cirrhotic, as we know, there is a portal hypertension, there is an effective hypovolemia, and that will increase the RAS system and will stimulate the sympathetic nervous system. So these are the two main actions or the two main players in the game in the patient with liver cirrhosis. Activation of the RAS system and activation of the sympathetic nervous system, because that will define the treatment that will be used to treat these patients. In pathophysiology, we'll find that the portal hypertension, which is in the stage of a liver cirrhosis, it will go to even a cardiomyopathy, as we will touch later. In cirrhosis, we have a portal hypertension, local production of vasodilators, we'll explain it later, and then we come to the decrease in the effective blood volume, together with a decrease in the arterial blood pressure due to splanchnic vasodilatation. However, there is an accumulation of evidence that in patients with non-alcoholic fatty cirrhosis, which is our problem or the main problem here in Egypt, we have non-alcoholic fatty cirrhosis. We find that many factors, they interact between the liver when it becomes cirrhotic and the production of some elevation of the arterial blood pressure. And we'll notice from this slide that as the disease is progressing, as the disease is progressing, we'll find there is an increase in the sympathetic system activity as well as the RAS system. There is increase in the activity of the RAS system. So this is the main physiology. This is the main player. These are the main players of the game. These circulating vasodilators combined with a decreased sensitivity to the vasopressors in such patients will decrease to vasodilatation and reduction of the vascular resistance. The overall systematic vascular resistance with a low blood pressure is most often the outcome of such patients who are presenting or they enter the process of hepatitis or the cirrhosis with an elevated blood pressure. They are often hyperkinetic, so they are simulating to some extent a hyperdynamic circulation, and the cardiac output increases. There is a decrease in the sodium and water, there is a sodium and water retention and there is presence of ascites. So, and this is really an important point because we have an ascites, yes, there is fluid in the abdomen cavity, but in the meanwhile, they are hypovolemic because this is important in the treatment as we'll touch now. Subject with arterial hypertension, secondary or essential hypertension can be normotensive, as we said. And they manifest in patients and even in cases with renovascular disease and high circulating renin activity. These findings are suggestive are due to increased cardiac output, secondary activation of the RAS system, as we said, and the sympathetic nervous system, and the release of vasopressin, with the resistance for the vasopressors. The vasodilator that acts are the adrenomyelin, calcitonin-generated peptides, nitric oxides, and other vasodilators. Two conditions, as we said, the cirrhosis may lead to affection of the heart. In fact, that is called cirrhotic cardiomyopathy. And the other, the simulation of the circulation like that of the sepsis, there is an expression here due to vasodilatations, splanchnic vasodilatations, hyperactive circulation. We have here what's called hepsis to simulate sepsis. That's why this slide will just summarize what we said as regard to the mean arterial blood pressure, comparing in the two middle bars. These are the patients with cirrhosis, and the other two bars are patients without cirrhosis. In the arterial blood pressure, it goes down a little bit. There is an increase in the increase in the cardiac output in such patients. There is a slight decrease at the circulating blood volume, as well as with a decrease at the splanchnic or vasodilatation of the splanchnic area. Okay, let's go to the antihypertensive medications. We have two problems. The first is the delay. In this patient, we have a liver disease. The liver is not working properly. When the liver is not working properly, we are giving a medicine. This medicine, if it's a pro-medicine, it needs to work in the liver to give the active metabolite, which will act to lower the blood pressure. In fact, we have an effect in this step. The other thing that the increase in the plasma concentration of drug metabolized by the liver. The drug either excreted by the kidney or by the liver. So medications excreted or metabolized in the liver are affected because the liver is not functioning properly. So we have to consider what? You have to reduce the dose of your medicine if it's metabolized in the liver. You have to prolong the administration intervals in the initial use, and you have to consider the safety of the liver when you are giving your medicine. So let's talk about different group of medications. Start with the non-selective beta blockers. In fact, the non-selective beta blockers are the most famous group of medicine. They are used for treatment of hypertension in patients with a liver cirrhosis, considering the propranolol. It's very effective, as well as it decreases the gastrointestinal bleeding and death in cirrhotic patient and reduces portal pressure. The other combinations, let's go back to the ascites. You have a patient with ascites. First thinking, I'll give him a diuretic. In fact, you have to be cautious about this. Because giving hydrochlorothiazide and chlorothalidone will leave the furosemide a little bit. But giving hydrochlorothiazide and chlorothalidone, it should be carefully in liver cirrhosis because they may precipitate coma. Remember, we said that these patients are hypovolemic. The RAS system inhibitors such as ARBs and ACE inhibitors suggested basic study prevent fibrosis, so they can be given. In a non-alcoholic hepatitis, ARBs are reported to be effective to reverse the pathological changes as fibrosis. Recently, just last year, we have this study that was published, and it showed that the affection or the impact of using ACE or ARBs on the reduction in risk all-cause mortality in patients with liver cirrhosis is more effective 30% than beta blockers. Beta blockers in liver disease In fact, they are the cornerstone, as we said. And we were talking about propranolol, which we don't use. We don't use Inderal, for instance, for treatment of hypertension, 3 doses a day or whatever. So they found that carvedilol is a new non-selective beta blocker that can be used for reducing blood pressure in patients with cirrhosis. However, using beta blockers, fixed doses are not discouraged. You have to control or to adjust the dose frequency according to the response. What about captopril, metoprolol, spironolactone? They are protecting. In the study, they found that they decrease the effect of suitable to reduce liver fibrosis. They are reduced liver fibrosis in vivo. Protecting effect of amlodipine and propranolol was only observed in high concentration. They did some very meticulous study. They studied the effect of the medications on the fibrosis that takes place in the liver. And they found that this fibrosis is affected or decreased whenever you are using the amlodipine and the propranolol, but in very high doses. Hepatopathy is induced with labetalol, methyl-dopa, so they are not encouraged. So don't say, no, I'll give a medicine that is safe, so I'll give alpha-methyl-dopa to 50, 500 milligrams 3 times a day just to help the patient. That will precipitate hepatopathy. Go back to furosemide, which is the first thing that will come to the mind of any patient treating a patient with ascites and hypertension. In fact, furosemide was found to be giving a highest signal for enhancing fibrosis in such patients. My colleagues, Mr. Chairman, in conclusion, arterial hypertension is seldom found in patients with liver disease. The choice of antihypertensive used for reducing high blood pressure might be crucial in patients with advanced liver disease, as they might, in the worst case, further promote liver fibrosis, while in the best case, even reduce or prevent its progression. Always remember that drug doses should be reduced. Frequency of administration are to be rescheduled. Non-selective beta blockers and RAS inhibitors are the first choice in treating patients in advanced liver disease. Diuretics are to be used with caution, as they may lead to coma. Furosemide potentiates more fibrosis in the liver when used. Labetalol and methyl-dopa can induce hepatopathy. Thank you very much.
شكرا للباشا دكتور ايهاب على المحاضره القيمه. اجملت فعلا وكلمتنا عن الليفر. هو حقيقه الليفر سيروزس غالبا احنا بنشوف العيان ده دايما بيبقى هايبوتنسيف عشان الفازو دايليت سبستانس اللي بتطلع دي والتوكسيكيشن بتاع الليفر والابيلتي تو افويد الاند ريزلت بتاعت معظم دراجز. لكن لما يبقى عيان ليفر سيروزس وهايبرتنشن يعني الموست يعني كوز يعني تتوقع يكون ايه في الحاله دي؟ ده السؤال الاول. السؤال الثاني اللي احنا الدراج اللي هو الموست يوز في حاله الليفر هو البيتا بلوكر. طيب لو بيتا بلوكر هو الموست بروبابل دراج في حاله الليفر، لو انا عندي كونترا انديكيشن للبيتا بلوكر في عين زي كده، شفت الايه يفضل ان انا اديله في الحاله دي؟ شكرا.
A very important questions. الحقيقه we'll start with the first one. الكوز حضرتك عارف لما when there is the liver affections عادة بنبتدي ندخل gradually في الهيباتورينال affection، وبالتالي الرينال affection may be the cause of hypertension in such patient. بالإضافة للessential cause، essential hypertension في عيان حصل decrease مع التشينجز أو الهيمودايناميك changes السبلانكينيك فيز dilatation decrease peripheral resistance and so on. بيحصل some decrease، ولكن هل البيشنت هيوصل إلى إن هو يبقى hypertensive ولا هيبقى مثلا moved من stage 1 لstage من stage 3 لstage 2 او من stage 2 to stage 1. فالessential hypertension موجود، عادة بيبقى renal hypertension بيبقى موجود in most of the patient. For the second questions حضرتك زي ما الستاديز قالت ان احنا بندي الحاجه اللي هي ما تضرش الكبد او ما بتعملش potentiation للفايبروزس مور، وهنا بيبقى الاس انهبيتور والاربس، وممكن الكالسيوم شانل بلوكرز هتيجي بعدين.
انا عايز بس استرس على حته في التشويس اوف دراج، يعني في التو برزنتيشنز ان احنا لو عيان ادفانسد ليفر ديزيز ذا بيست تشويس هو راس بلوكيد. هنا العيان بوست ترانسبلانتيشن is not preferred، يعني بيبقى محتاج الكالسيوم شانل بلوكرز والبيتا بلوكر، فدي برضو نقطه مهمه. بالنسبه للراس بلوكيد، هل يعني في سبيشال دراج تو بي يوز مثلا زي اس انهبيتورز؟ يعني احنا عارفين ان الفوزينوبريل 50% اكسكريشن هيباتيك و50% رينال، فهل في تشويس معين للاس انهبيتورز which اس انهبيتور تو يوز، ولا مفيش ريفرنس على
الستاديز اللي هي كانت ريليتد للسيفتي اوف ذا ليفر ما قالتش ان في حاجه معينه، ولكن مثلا في سيتويشن زي في الهيباتيتس سي الانالابريل اتس نوت indicated too much because of interactions with hepatitis C medications with antiviral medications.
في الحقيقه في فرق بين حاله السيروز العاديه وحاله الترانسبلانتيشن، ده احنا دخلنا في ايرا ثانيه في
different pathology تمام.
في الواقع المحاضره قيمه جدا لانها وضحت علاقه الليفر various drugs we are using. احنا in our country we have a high percentage of liver disease. فبنستعمل الدراجز اللي الدكتور منى الاستاذ قالها كلها كل يوم بنستعملها. فطبعا اوضحت علاقه الدراجز دي وازاي نبقى في دراجز نقدر نستعملها وفي دراجز لازم نبقى فيه with caution بالنسبه لها. فطبعا حضرتك كانت قيمه جدا وانا اشكرك على هذا الحقيقه.
في سؤال يا دكتور ايهاب. دكتور علي اسف عاوز اسال سؤال دكتور ايهاب.
This particular patient, we need smaller doses of drugs, as you said. Could you start by 2 drugs instead of 1, and what combination you prefer in this situation?
It's a very important question. The point is it depends the combinations. There is no objection to just combine medications, ولكن الكومباينيشنز هتبقى من الادويه اللي هي هتبقى مفيده للبيشنتس ومفيده ان هي بروتكتيف للليفر. انا ممكن ادي كالسيوم شانل بلوكرز مع ايسياس، ممكن ادي كالسيوم شانل بلوكرز مع اربسياس، ممكن ادي بيتا بلوكرز مع ايسيا. can be. So there is no problem in giving a combination, providing that usually in blood pressure it's not that high in such patient نتيجه للفيزودايليتيشنز ان انا ممكن اوصل للcombination. ولكن if it's the situation it's just like that ان انا هدي combination therapy to control blood pressure, yes can be from ال good medications او يعني medications of benefit اللي موجوده.
شكرا دكتور ايهاب.
أنا الحقيقه يشرفني ويسعدني ان انا اقدم لكم الاستاذ الدكتوره سهير عمر الخشاب. وانا مضطر ان انا اقول انها بنت عالم كبير جدا من علماء القصر العيني، الاستاذ الدكتور عمر الخشاب، استاذ النفرولوجي في القصر العيني الشهيد. وبعدين اسمها الاسم سهير ده، الاسم ده ما جاش عفوا، ده لانها حفيده الاستاذه العظيمه والاديبه الكبيره الشهيره سهير القلماوي.
ربنا يخلي حضرتك. شكرا.
الوراث حاجه وراثيه في العائله، هذا المستوى العلمي الرفيع، ونتوقع اننا هنسمع منها محاضره قيمه جدا عن نفروباثي في الحالات هايبرتنشن.
Thank you very much, Mr. Chairman. It is an honor to be among you. I will start my lecture. It was a very interesting topic, actually. Nephropathy as a neglected target in treatment of hypertension. We will be discussing the following points. First, I will start with what's the definition of chronic kidney disease. As you all know, it's irreversible, progressive, more than 3 months deterioration of kidney function. But what we all neglect is the real definition as defined by the KDIGO guidelines is that the chronic kidney disease does not start with a decline of creatinine, it does not start with the initiation of proteinuria, but it starts with a hyperfiltrating kidney. So at this stage of G1, there is only hyperfiltration, and at G1, A1, there may be no proteinuria or very low amount of proteinuria associated with a hyperfiltrating kidney and a normal creatinine, and this is what most of physicians miss At the second stage, there may be still a normal creatinine. So renal failure, as manifested as presented to us, presents with stage 3 kidney disease, and this is a very crucial point in how to target hypertension in nephropathy, as nephropathy starts earlier than where we start as physicians. Most definitions are based upon the GFR, and the GFR is a very unsatisfying calculation of the renal functions for us nephrologists per se. As you see, there are always new GFR and estimated GFR methods to calculate. They are very disadvantageous, although inexpensive and convenient, yet they do not take into account the age, sex, race, body mass index, diet, hydration, medication of the patients, and they often overestimate and underestimate. So all the decisions you may be taking upon an estimated GFR written in a lab report may be very misleading. If you ask your patient about whether the lab took his age, height, or weight, you will be getting an answer of no. So all the estimated GFR you're taking the decisions upon is not right. So what about the definition of hypertension? Is it that accurate? As you see, this is the American classification of hypertension. The European classification of hypertension is different and states that hypertension is at a high, or the definition or the diagnosis of hypertension should start at a higher level, and this target of low blood pressure should be targeted only to high-risk cardiovascular disease or chronic kidney disease patients. But does this classification or even the European classification take into account how this blood pressure is measured, whether the home monitoring or the ambulatory monitoring, or as you previously mentioned, whether the patient is very stressed, works in a very stressful job, whether his blood pressure rises instantaneously, and it does not also in no single trial is this category of patients upon which I'm going to talk now is addressed. Those patients who have low normal blood pressure, a person who has a blood pressure of 80/50, and then his blood pressure rises to 100/70. He does not fall into the classification of hypertension internationally, but he has nephropathy? Does he have an target organ damage? Actually, no one is answering this question. Again, to the definition of hypertensive nephropathy, it is kidney disease associated with high blood pressure. It is hypertension is currently defined internationally the second cause of renal replacement therapy. It is poorly controlled in chronic kidney disease, and regardless of the cause of chronic kidney disease, once hypertension starts, chronic kidney disease accelerates, and a very vicious, malicious circle starts. Previously, the estimated GFR was used as a measure to control or to modify or to treat hypertension, but all recent studies suggest that urinary protein creatinine ratio is strongly and more accurately associated with the systolic blood pressure increase than the estimated GFR. From a nephrologist's point of view and from a philosophical point of view, a very important point is that hypertensive nephropathy is actually, let's say, a reflection of how nephrologists do not dig into the real cause of the nephropathy, because in all trials, the control of hypertension did decrease the mortality of stroke, the cardiovascular risk, but it did not decrease much the progression of nephropathy. So the cause of this is that investigation of the cause of nephropathy might be expensive, and finally it will not have a major impact on treatment, but currently, but for the future, maybe it will. Common causes or investigated causes are genetic causes, small vessel disease, and also obesity. Once this starts, this does not stop, and hypertension aggravates and chronic kidney disease aggravates. Well, the incidence, I will not go into the incidence of hypertension, but I will go into the incidence of chronic kidney disease. 1 in 3 adults are at risk of chronic kidney disease. Etiology, as previously mentioned, it is maybe genetic obesity, and it is definitely under-investigated, and there is no change in treatment strategy. Whether pathology and pathogenesis are out of this lecture, but I just want to mention them briefly because they may have an impact on treatment in the future. There is glomerular fibrosis, and previously it was thought that only glomerular changes occur, and these are the only changes that lead to this fibrosis. But recently, it was found that there's also tubular mesenchymal epithelial mesenchymal transition leading to tubular also fibrosis. There is podocyte loss, and there is also a change in the smooth muscle cells. A very actually interesting procedure happens, which is the change in the structure of these smooth muscle cells, which makes them more liable or more causing hypertension, and hypertension leading to more glomerular filtration and chronic kidney disease. This is a very interesting slide for me. This vicious circle of systemic hypertension and glomerular hypertension, this is the old theory, but the new theory also is this vicious circle of the renal growth factor excreted by the increased GFR, leading to more transdifferentiation of the not only the renal glomerular cells, but the renal tubular cells, and the transition of this viable kidney into a fibrotic kidney. So this is the summary of the mechanism of renal injury. So, well, about the clinical picture. The clinical picture of hypertensive nephropathy is actually very, very non-specific, and if you apply this to a patient, for example, with early diabetes having impaired glucose tolerance, nothing else, this will apply. And he may be having hypertension because of the impaired glucose tolerance and because of the diabetes, or a patient of Alpert. And although Alpert or impaired glucose tolerance may not have an impact on treatment now, but maybe in the future. What about the investigations in a case of hypertensive nephropathy? Well, I'm just highlighting the most important for practice. You don't measure only creatinine, but most importantly, you measure proteinuria. And proteinuria, we measure it by two methods, the albumin-creatinine ratio, but actually the 24-hour urinary protein is the more accurate. And there is a lot of fallacious albumin-creatinine ratio. For example, if your patient has a UTI or he had massive exercise, you will have a falsely high proteinuria, and you will be taking a wrong decision upon this fallacious proteinuria. You should also be measuring the uric acid and definitely the hypercholesterolemic profile. Welcome. Now for the most important part of this lecture. What about the treatment? What should we doing? We should all revert to the origin of the medicine. No harm. And no harm starts with prevention. And prevention we all underestimate, and the trials and the pharmaceutical society, and we as a medical society, we underestimate the effect of a good diet, a low salt diet, a good hydrating patient. So prevention, or the treatment of hypertensive nephropathy, whether hypertensive nephropathy or nephropathy leading to hypertension, should start by prevention. Then we have the medical and the surgical, and maybe in the future, the regenerative and genetic. I will discuss the current and the treatment for the hypertension in nephropathy, and also the new treatment for hypertension in nephropathy. As you all know, the ACE and the ARBIS and the RAS blockade, no one disagrees now that the RAS blockade slows the chronic kidney function, and regardless of the creatinine, ACE inhibitors or RAS blockade can be instituted, taking into consideration only that we should be monitoring that patient for the rise of creatinine and the rise of the hyperkalemia. Adding spironolactone to this combination may lead to more adjustment of hypertension, but will definitely lead to more hyperkalemia. In a recent study called the CLICK study, chlorothiazide was added to spironolactone in order to gain the advantages of spironolactone and disregard its side effects. However, it did not mention that adding spironolactone to chlorothiazide will lead to more dehydration, and with this will make the patient go into recurrent attacks of AKI, and this is very hazardous to the patient. Answering the question, should we stop ACE inhibitors for a declining renal function? Actually, the STOP trial, ACE trial, answered this question, and the answer is no. We should not be stopping it, but we should be hydrating our patients well, because actually there was a trend towards earlier dialysis in patients who stopped ACE inhibitors even in advanced stages. What about the RAS blockade in renal transplantation? Well, the transplant community is still questionable about that, because you should be knowing that a transplant kidney does not have a normal GFR. This is a stage 1 renal disease, or we call it stage 5. Is a certain ACE inhibitor preferable? Well, they're all of equal, let's say, efficacy. One having a disadvantage over the other, and one having a disadvantage over the other. But there's a recent study saying that losartan has another effect besides the decrease of the glomerular filtration, or the decrease of the glomerular hypertension. It has a cytoprotective effect, and this addresses the mechanisms or the pathological mechanism I previously described. The non-steroidal mineralocorticoid receptor antagonist was also associated with a decline of chronic kidney disease. The finerenone also, the aldosterone synthetase inhibitor also. They are all only associated, unfortunately, with hyperkalemia. The endothelin antagonists also. The renal denervation was addressed in 2015, and all trials said the hazards exceed the benefits. However, recently the trials in 2022 readdressed that. The highlight of this year was the FDA approving the Jardiance or the empagliflozin as a treatment for chronic kidney disease. There are many advantages, and the CSLT are not all the same. There are benefits and there are contraindications. I will just this is actually my before last slide. You should not be using SGLT2 inhibitors in estimated GFR above 45. And every year they decrease this estimated GFR. Recently it's 25. And 25 is not a very good renal function. 25 maybe a creatinine of 2. 45 maybe creatinine of 1.7 or something. It should be very cautiously used in elderly and in children, and it's contraindicated in patients who have recurrent UTI, ischemic lower limb, recurrent hypotension, recurrent hypoglycemia, and you should be very aware of the euglycemic DKA. Patients who have Frogs-Ziga, regardless of the chronic kidney function, may have DKA and it's euglycemic. This is the last slide. Early detection of chronic kidney disease and hypertension is the essential part of treatment, and detection the original disease is most important. Proper monitoring is of utmost important. Last but not least, individualization, precision medicine, and personalized medicine may be the aim for the patients. Thank you very much.
We thank Professor سهير الخشاب على هذه المحاضرة القيمة. For the sake of time, we end this session. لا يفوتني في هذه المناسبة أن أشيد بالأساتذة الذين أقاموا هذا المؤتمر والهيئة المنظمة لهذا المؤتمر، وأهنئهم على هذا النجاح العظيم. والنجاح ده لم يأتي من فراغ، وإنما أتى بمستوى رفيع للبرنامج العلمي، اختيار موفق جدا للسبيكرز، تنظيم جيد جدا للمؤتمر. فأكرر تهنئتي وأتمنى لهم من نجاح إلى نجاح.